Yesterday, health information moved by U.S. mail, overnight delivery, fax, or in a box in a patient's trunk. Today, we see information being captured electronically, but it still moves in old-fashioned ways. But we're starting to see a glimpse of tomorrow, when information flows electronically, securely, freely, and respecting patient privacy on a national scale. More than just computers and networks, this requires a set of processes that we all adopt in order to establish an environment of trust, a trust framework for exchanging health information. This is a story of intercommunity and interstate trust. Emily is a 70-year-old woman who lives in California and is flying to Oregon to visit her daughter. When Emily arrived, she experiences trouble breathing and is rushed to an emergency room at a local Salem, Oregon hospital. When Emily and her daughter arrive, Emily is admitted to the hospital, where she undergoes a series of tests revealing that she has congestive heart failure, a new condition for Emily. Emily arrives back in California and makes a follow-up appointment with her primary physician. Before health information exchange, Emily would have seen her primary care physician without any information from her hospital visit, and her doctor may have waited days or weeks to get her test results, as they slowly moved through fax machines, mail, or sat on the desk of a busy office. Today, the National Association of Trusted Exchange is creating a trust framework that enables physicians, clinics, and hospitals to find and use electronic methods of communication to exchange medical records across state lines while preserving security and patient privacy. Dr. California locates Salem Hospital Medical Records Department in the provider directory and sends a secure direct message requesting Emily's discharge summary. The hospital in Salem receives Dr. California's request and sends the discharge summary to him, where he reviews the information with Emily. Emily and her doctor note the new medications added during her hospital visit, as he makes adjustments based on the information he received, and refers her to Dr. Hart, a cardiologist, for her newly diagnosed condition. The HIE landscape in California comprises over 30 existing and emerging community and enterprise health information organizations, many using direct. California is likewise creating a trust framework for otherwise unaffiliated communities that have reasons to share patients, where they can locate referring physicians convenient to the patient and send them records to prepare them for the patient visit. Dr. California is not a part of Dr. Hart's clinic or hospital system, so he looks him up in the provider directory and sends him a secure direct message with a request to see Emily, attaching records from her office visit and the discharge summary from Salem Hospital. In response to Dr. California's message, Dr. Hart looks up Salem Hospital medical records and sends them a message requesting the X-ray and cardiac ultrasound that were the basis of Emily's new diagnosis of congestive heart failure to prepare for her visit. This story shows how health information exchange led to faster, coordinated care. Because of the electronic exchange and the trust framework, Dr. Hart was able to get the tests that were done in Oregon without having her repeat all those tests. He was able to implement an intervention faster, and this saved her time and money and got her on the road to managing her congestive heart failure much quicker. She had a better health outcome and got back on her feet, ready to enjoy her life, all because of health information exchange.